Hi, my name is Eross. I'm from Budapest, Hungary. I work as a neurosurgeon at the National Institute of Clinical Neurosciences in Budapest. Neuromodulation is the latest techniques what we use. Probably all those who are treating pain patients knows that the beginning of the pain treatment started with ablative procedures, which was done by neurosurgeons. Then drug therapy came and took over the field of pain therapy, and then minimal invasive pain procedures came with the help of anesthesiologists. So nowadays anesthesiology is dominating the pain therapy. In the last 50 years, neuromodulation arrived through the invention of neurosurgeons in the form of spinal cord stimulation and deep brain stimulation, later on peripheral or regional stimulation, ganglion stimulation. So in neurosurgery we are depending on imaging. Because we always have to know exactly where we go into the brain. And now these new imaging techniques, what we have, DTI, segmentation of the deep nucleus, we can see much better our targets and eloquent areas with functional MR and other form of imaging. And in the last couple of years, robotic neurosurgery started to develop quickly, and it had the high accuracy for the treatment of our patients. In Hungary, we do all form of pain procedures and neuromodulative techniques. In our institute, which couple of years ago was the third biggest in Europe. We do ablative procedures, minimal invasive procedures, and DBS, motor cortex stimulation, Gaussian ganglion stimulation, intrathecal drug delivery for spasticity, for pain, and spinal cord stimulation, obviously. Insurance companies always want evidences to cover procedures. In neuromodulation, we have such a boom, not only in pain therapy, but in movement disorders, in epilepsy, in spasticity, that the data, what we are able to gather in a certain amount of time is not enough, obviously, for proper reimbursement. In Hungary, we are in a relatively good balance of reimbursement and the needs what we have. In movement disorders, in Parkinson's patients, in epilepsy patients, in epilepsy surgery, or in pain therapy, we don't have long queues to wait. The national insurance is covering relatively well the indications what we have. Obviously, the new methods, which is arriving year by year, is not covered all. But we continuously negotiating, and if there is only a slight difference between methods or equipments, it's interchangeable. So we can change from one type of equipment to another type of equipment if the therapeutic results is similar. It's interesting that the neurosurgeons are not devoted for pain therapy. Probably because it needs a complex team of people, and neurosurgeons are doing the practical, technical part of the neurological treatment of neurological disorders, and pain therapy is really a very difficult thing because it's not a one-man show. You need to know anatomy very well, neurology very well. You need to know the drugs very well. You have to be well equipped. You need to have psychologists, psychiatrists in the team. So it's a complex, and the main problem is the reimbursement of the pain therapy is not everywhere well established in different countries in Europe. So neurosurgeons is doing mainly tumor surgeries, and the functional neurosurgical units is concentrating on epilepsy and movement disorder surgeries. In spite of that, neurosurgeons started to treat pain with ablative procedures. Now, and there was a period of 50 years where the drugs dominated the treatment because there was not development in the surgical field. Now invasive neuromodulation will bring back neurosurgery to the field of pain management. I think miniaturization, brain-machine interface developments, the new development in the current sources, that would help us a lot, and which is very important, we have to find where and how to stimulate the central nervous system, because just simply sending electric signals to the nerves, we don't really know are we stimulating or blocking the neurons, or a block of neurons within the brain or within the spinal cord. And as now we know from the basic research, it's not the same in every second or millisecond or microsecond, because there are periods where we can effectively stimulate the neurons, and there are periods during stimulation where we cannot reach our goal, because there are certain periods when the neurons cannot be stimulated, and we know it from epilepsy, and probably we can bring this novel knowledge to pain therapy as well, to be more effective. So translational research is very important, and it doesn't mean only to do pain research for clinical pain activity. So, I mean, pain research for pain treatment, but probably we have to bring the knowledge from other disciplines like basic neuroscience, epilepsy research, the movement disorder research, because the system is the same, what we would like to treat, just the disorders are different, but the approach, what we do during research, is different in epilepsy, in movement disorders, and in pain. And if we synthesize this knowledge, probably we can help from discipline to each other to implement novel approaches, novel techniques, and design new equipments.